new approaches and to try to offer new therapies to patients. First of all, let's go through a few sickle cell facts and what I believe it's very important to know about those new therapies, new drug developments. And one of the reasons is to think about sickle cell disease. Well, we certainly know that it's one of the most prevalent genetic disease worldwide. It still has reduced life expectancies, and it has a high disease burden. Next. The other thing is that we so far have only one drug, hydroxyurea, that is clearly well established to have reduced disease burden, but do not completely alleviate disease manifestations. And we certainly have a lot of examples of patients that continue to be significantly affected by sickle cell disease in spite of taking hydroxyurea very regularly. 2, in Canada, believe it or not, hydroxyurea is still not listed as an indication for sickle cell disease, and we still use it as an off-label. Fortunately enough, we can prescribe it, but that leads to certain difficulties when we want to continue to study certain things about hydroxyurea. And I still believe, I'm sorry to use that term, but I think in Canada in 2024, this is absolutely not acceptable. There are curative therapies that exist and bear certainly high expectations, and Donna is going to talk about all those, but they remain limited. There are not centers everywhere throughout Canada that can offer those therapies. They bear high cost. Long-term efficacy of gene therapies, for example, still remain to be determined. And patients with non-SS disease often do not have access to such therapies. So that's one of the many reasons we continue to require drugs and new therapies for sickle cell disease besides hydroxyurea. Next slide. Some facts about hydroxyurea to continue on this. Although it's quite accepted and it's highly recommended, it's still being used off-label. I told you about this. And just bear in mind that many of the new drugs that I'm going to talk about have been used in conjunction with hydroxyurea. And many studies demonstrated that those new therapies work better when they are combined with hydroxyurea and not in replacement of hydroxyurea. So we need to continue to learn on how to better use hydroxyurea and how to use it more effectively. Next. And if we think about hydroxyurea, that's going to be the same thing for any drugs, old or new. Repeat the importance of adherence. If you don't take the drug, well, of course it won't work, right? And that's one of the recent studies about adherence to hydroxyurea. If you look at disease failure probability and the number of vaso-occlusive-free crises, if you're adherent versus not adherent, well, the probability of having more crises, of course, it's associated with less adherence. So if you're more adherent, well, you're going to be, your medication is going to be more effective. Next. Okay. So let's go through new therapies. And we're going to focus on sickle cell disease. Hydroxyurea, that's more, I think, a European, based on the European market, where hydroxyurea has been approved more lately than in the US. US approved hydroxyurea for the adults in 1998, and a little bit less than 10 years ago for kids, 2 years and above. More recently, we have L-glutamine, voxelotor, and crizanlizumab, and I'm going to focus on this. We can talk on many other drugs because there are dozens and dozens of new medications that are being tested and evaluated. And it's really flourishing and fascinating to see how things are going. Next slide. So let's talk about voxelotor, L-glutamine, and crizanlizumab. That appears to be the 3 new players since 2019, where the FDA approved those medications, and where at least 2 of the medications were pre-approved by the EMA as well. Next slide. So let's talk about L-glutamine. I'm going to go very quickly on L-glutamine. And just to say, next please, just to say a few things. So it was approved by the FDA in 2019, but again, as for Hadria, L-glutamine remains still non-approved in Canada. Efficacy has been demonstrated in a phase 3 trial published in 2017 in New England Journal of Medicine, where it demonstrated that patients taking L-glutamine had fewer crises and fewer hospitalizations than those who received placebo. However, results in previously published other studies had very conflicting results. And whether or not it is very efficacious, the efficacy is quite high, in my opinion, remains questionable. The mechanisms also remain quite poorly understood. And L-glutamine, also, there are some other questions that remain. The L-glutamine was compounded in pockets of 5 grams. Patients had to take it twice a day with beverages. The cost is estimated to between $1,000 and $3,000 per month. So whether or not some companies are going to cover this in a medication that has a questionable effect and question mark about safety profile, I'm not sure about this, okay? So am I putting my bet on that medication? Personally, that's not, it's not where, I'm not really pushing for the use of L-glutamine. It might help some patients. I'm not saying it doesn't have any efficacy. It might do it might have some effect, but there are still some concerns. And among the concerns, I'll try to speak louder then. Among the concerns, there had been some higher mortality rates observed when used IV in patients that were critically ill, particularly in liver failures or kidney insufficiency. So caution remains in patients with renal or liver dysfunction, that something that is quite frequent in our adult population. And if you look at the phase 3 trial published in New England Journal of Medicine, there had been 2 unexplained cardiac deaths in the medication arm, none in the placebo. And that really is kind of troubling. Okay, next slide. Crizanlizumab. Crizanlizumab is an antibody that works against selectin. It is a protein that can leads to adherence of cells on the endothelial and participate in the blockage of the circulation. And if you block that protein, then particularly the blood cells, the white blood cells, flow more freely and do not adhere to the endothelial. So there has been preclinical studies that demonstrate that anti-selecting agents tend to reduce the risk of vaso-occlusive crisis, either on the acute phase or given preventively. A phase 3 trial in 2017 demonstrated that there was less crisis and that patients that received crizanlizumab had more times spent between the second and the third crisis. Next. Higher dose worked better. Next one. I'm going to go very quickly with this. But the EMA, the European Drug Approval Committee, has revoked the approval for crizanlizumab. Why was that? Well, a further study has demonstrated that preliminary results led to very deceiving results, and that the crizanlizumab had no statistically significant difference between the groups, between each dose, middle dose, or higher dose versus placebo in the annualized rates of vaso-occlusive crisis. And further ongoing studies are also deceiving. So there are still question marks whether or not crizanlizumab might be effective, and at least in the European Union, that drug approval has been revoked. Next one. Is still medications to keep in mind, particularly for patients that develop priapisms, something you're going to hear about with Dr. Madeleine Verhulst later on today. So priapism is the particular pain crisis that affects male. And when given preventively, what appears to be in the Spartan study that really looked at the number of priapism episodes in patients that received crizanlizumab versus placebo, those who received crizanlizumab had, most of them, reduced number of episodes. That's the baseline. If you're lower, you have fewer episodes. So you see that you had some patients that had more episodes of priapism, but a majority of patients had reduced number of priapism episodes. So knowing that those patients had at least 2 to 3 severe priapism episodes to be entered in this study, you can imagine that a reduction of the priapism episodes leads to improved quality of life. So I think that for patients that have priapism, it's an interesting drug because so far we do not have very good drug for that particular sickle cell complication. So I think it's something to keep in mind, and I wouldn't throw crizanlizumab completely and keep that as an indication for pain crisis, as particularly for priapism, probably not for other indications. Next slide. Let's talk about voxelotor. Voxelotor is a drug that goes in the pocket where hemoglobin interacts with each other. And it leads to an anti-sickling effect. If you can imagine that's a hemoglobin S here, that it has no oxygen, that's another hemoglobin S here. When it's deoxygenated, it binds together, and it leads to crystallization, deformity of red blood cells. So if you block that crystallization process, and that's what voxelotor do, well, then you have decreased sickling mechanism and potentially improve the severity of anemia and potentially other clinical effects. So let's see what it did. Next. So that's the HOPE study published in 2019, and you see that only 9% of patients had hemoglobin response. That study was the first study not to look at clinical episodes such as pain crisis or chest syndrome. It looked instead of on the results of the correction of the anemia. And the primary objective was to look at that increase in hemoglobin level. So you see that almost 60% of patients, 6 out of 10, had a significant increase in hemoglobin level, some of them more than 2 grams per deciliter. So that's quite significant. If you have a patient that has a baseline hemoglobin between 60 and 70, to have, with that medication, hemoglobin that goes up to 80 and 90, you can imagine that they might have an improvement in their quality of life. Okay, next slide. Long-term results demonstrated that there was a sustained effect with the use of voxelotor. Next slide. However, there are still some question marks about this. And I really like Charles Quinn on that quick note published in 2022. So what it really, they looked at, what I showed you before. Many patients have an increase in hemoglobin. Some patients do not answer, and some other have decreased hemoglobin. So his practical approach to the use of voxelotor is the following. Given that patients will respond to voxelotor within 4 to 8 weeks, his approach and suggestion is to propose these medications to patients that are severely anemic to improve their degree of anemia, and that if you do not see any effect within 4 to 8 weeks, to stop the medication, because those are the non-responder patients. If you see an increase in hemoglobin, well, continue using it. And the other thing is that with the voxelotor, one of the things that it has is that it also changed the ability of the hemoglobin to fix the oxygen and particularly to release the oxygen. So it means that there is a potential risk that tissues receive less oxygen. So their caution is that if you have a patient that might have already some damage, particularly silent infarcts. If you put them on voxelotor, we don't know if you might have more silent infarcts in those patients. And in those patients who may respond, they would use a caution to follow carefully patients with brain MRI to make sure that they do not develop damage. Whether or not it's a true risk, it's unknown, but I think it's an important thing to keep in mind. So I like this practical approach, and I think it's an interesting medication. Unfortunately, voxelotor so far was not shown to have an effect on vaso-occlusive crisis and very minimal effect on acute chest syndrome. But if you have a severely anemic patient, I think it's something that is worth to use. Next slide. We can talk on many other new therapies, and among all of them, I've picked my favorite. I'm certainly biased because I participated in two studies that use those medication. I'm almost done, right? So I might be biased, but why is it that favorite? Why is those medications my favorite? I'll go through this I'll try to do this in 2 minutes. Okay, all right, let's go. Deep breath, we go through. This one is pyruvate kinase allosteric modificator. PK is an important enzymes within red blood cells that improves energy in the red cells. And red blood cells, to maintain their integrity, needs energy. So if you improve the quality of your red blood cells battery, if you would see that, well then your red blood cells may maintain its integrity a little bit better and may have longer half-life. Next one. So there are 3 medications, 2 of them that are under study, etavopivat and mitapivat. They bind at different sites on PK, and there is one that is still ongoing on development, the AG946, that is kind of interesting. There are studies for etavopivat and mitapivat. Next one. So why I find this medication interesting, in contrast to other new agents, the effect of PK activators goes beyond the effect on the hemoglobin oxygen stability. It improves red blood cells physiology. It reduces the red blood cells fragility. But if you increase the number of energy, ATP is what we use to move our muscles, to strengthen our blood vessels, or to work on their elasticity and response, okay? So if you have more ATP, well then, in the red blood cells, well, some of the ATP goes out of red blood cells. So it might help to maintain the integrity of the endothelial and maybe to maintain healthier endothelial. Next slide. So there are different things that the mitapivat does. There has been a couple of studies. They so far showed a significant increase in the hemoglobin level, reduced hemolysis markers. I get it. Next one. And if you look at the energy level, like the ATP level, 2 or 3 DPG, that's the affinity of the oxygen, the hemoglobin. You see significant changes, and those are something that is reversible if you stop the medication. Okay? Next one. Let's skip that. Okay? Let's skip that one too. So there are a couple of studies with mitapivat. Raise Up is a double-blind, randomized, controlled, multi-center study efficacy for the safety on mitapivat on sickle cell disease. There is a phase 2 study that is praised on the etavopivat in adolescents and adults, either for patients that have beta thalassemia, transfused or non-transfused, and patients with sickle cell disease transfused for primary stroke prevention. There is the Hibiscus study that is a phase 3 double-blind study for, again, adolescents and adult patients that do not receive transfusion Okay, next slide. So preliminary results of the Raise Up study demonstrated a significant increase in hemoglobin level and possibly a tendency to have less vaso-occlusive crisis. So I think it's a very promising drug. Next slide. So in conclusion, I think the future continues to be quite promising with further drug development for our patients with sickle cell disease. And I think the futures might be more in combination therapies rather than replacing hydroxyurea with another therapy. And I think those developments remains pivotal. And I can't reinforce more the fact that we need advocacy, and I think we're definitely right here at the best place for that, to improve equitable access for new therapies for Canadians, including our famous, very new drugs, that is hydroxyurea, that you all know about since more than 40 years now, okay? So that's it for me. And I'll pass it on to Donna, and you will talk on stem cell therapies and gene therapy.
Perfecto.
Thank you, Dr. Pastore. I know you had to fly through that, and I really appreciate your expeditious jaunt through all the variety of different therapies. We now have us joining Dr. Donna Wall all the way from the West Coast, flew in on a red eye. Gnarly dude. I mean, you're a rock star in more ways than one. She's recently moved from professor to professor emeritus, if I'm saying that correctly. So. And before retiring from Sick Kids and moving to the West Coast to ride some waves, she was, section head of the Blood and Marrow Transplant and Cellular Therapy Division, and she was section head of the Division of Hematology and Oncology at Sick Kids. At the time, she joined the HSK, or Hospital for Sick Kids, in 2016, and the University of Toronto in the fall of 2016. And after completing her pediatric hematology/oncology training in New York and Boston, she went on to establish bone marrow transplant and public cord blood banks in St. Louis and San Antonio. She's led the Manitoba Blood and Marrow Transplant Program, including Manitoba Center for Advanced Cell and Tissue Therapy, and is currently riding waves in California. So without further ado, Dr. Donna Wall.
I won't do any jokes because I want to save all my time. I did scam some time from Kevin Koo, who's on call, so he graciously gave me his time, and I'll also cover his area. May I have the first slide? And next slide. So I do have some disclosures. And first of all, I did run the Vertex CRISPR trials at Sick Kids for both thalassemia and sickle cell. And we're very proud to work with the Thalassemia Foundation on a trial that we've just completed and is just sent out for publication for a novel transplant regimen that looks very promising for sickle cell patients as well. And I now am helping out Vertex and Editas with the development of a rational rollout of these therapies. Okay, so this is what I'm up to. Next. Okay, my goal today is to get you guys ready for the tsunami of questions you are already getting or will be getting from your patients with hemoglobinopathies as to why can't I be cured now and get it fixed. There's a big pressure, which we're not used to, of direct marketing to our patients and families. The social media and the web is just really getting a lot of excitement going, and I spend half my time just putting the brakes on things and reality testing some of these things. So first of all, sickle cell, simple disease, one amino acid. How hard can this be? Hey? The phenotype of it, how patients live with their sickle cell disease, is widely variant, and we are still very much learning about why some patients have a really terrible time with things, others are diagnosed in their 60s. Like, it's a wide range of presentation. Also important is we, up to this point, have been applying curative therapies to patients who we know are sick, who have told us, I'm having acute chest syndrome, my kidneys aren't working, I have recurrent vaso-occlusive crisis. Increasingly, we're seeing publications that are going to completely cloud the decision-making process of the insidious subclinical damage that's caused by ongoing sickling in patients who have not yet told us that they're sick. So my colleague, Dr. Kumar at Princess Margaret, and anybody doing adult medicine are going to say, you know, sickle cell is a terrible disease. You know, much, much different than what we see in I'm a pediatrician, by the way, in pediatrics. So, you know, the kids are cute, they take the hydroxyurea, they just kind of smoke all the way through, and then they go to the adult side and like, whoa, all hell breaks loose, pardon me. And just out in Blood this month from the folks at St. Jude's, where they did serial MRIs of the heart showing the cardiac contractility in patients with sickle cell anemia, pre-bone marrow transplant, post-bone marrow transplant, pre-gene therapy, asymptomatic, that the cardiomyopathy that's seen in older patients is present early on in teens and can be identified, and importantly, at least in St. Jude's hands, has shown reversal of the cardiac changes after bone marrow transplant. So you stop the sickling, the heart gets better, okay? And so this is a very important paper just out, and there is also work coming on what are the subtle changes that happen with the silent infarcts that we pick up on MRIs of the brains, the blood flow measurements that we do with ultrasounds, what that has in the subclinical end of IQ, learning, lifelong functioning. And there are very good trials ongoing suggesting that we might be needing to push the button, or it may be in the next 5 years when, you know, the next time someone gives this talk. This is a very different talk, and the indication to go to curative therapy will change. Okay, next. Okay, gene therapy, transplant, it's all the same. Okay, it's all the same. Okay, all curative therapies focus on the hematopoietic stem cell. Okay. Nothing scary about this. And the idea is our blood-making factory is driven off the hematopoietic stem cells. If we want to make a change in what our red cells look like, we have to correct the guy who's going to make the red blood cells down the road. So all the therapies, all we care about is the correction of the youngest of the blood-making cells. So when we do a bone marrow transplant, we get somebody else's blood-making cells and pop them in. Now, to pop them in, we can't just put them in the blood and they go into the bone marrow. That we know happens. But if there's no space in there for them to get their way into the niche, the hematopoietic niche where the young blood-making cells sit, they're gonna just die off. Okay, so we have to use radiation therapy or chemotherapy to make space for these young blood-making cells. When we do gene therapy, the difference is all we're doing is, instead of using somebody else's youngest of the youngest blood-making cells, is that we collect the cells, as Dr. Kumar had talked about earlier, from the patient themselves. Take that to the laboratory, fiddle with it, and I'll run through several strategies with it, and then it looks just like a bone marrow transplant. Okay, we can't just pour the guys back in. We have to use the medicines or strategies that make space. In gene therapy, that right now, by experience, is all the gene therapy trials use busulfan, which is a very strong chemotherapy drug. We don't like using it in bone marrow transplant. It's terrible for fertility. It's got real risk in the liver. It's really not our favorite drug. And that's what Dr. Kumar had alluded to. We have to be incredibly careful with giving it. We know that there are side effects with it. And so right now in 2024, all the gene therapy trials, all the patients are going through what looks just like a bone marrow transplant, okay? So this is not just gene therapy, okay? So just so that you can go. And I've seen beautiful things happen with the gene therapy, but it just so that you know, right now, the investment is at least a year to a year and a half of we're in your face period of collecting young blood making cells, getting them corrected. Well, maybe the correction didn't work, so we go back to the beginning, we collect again. Maybe we didn't collect enough, we do it again. Like that whole process is arduous. The hospital stay is a bone marrow transplant. It looks just like an autologous bone marrow transplant. The length of stay is probably a little bit longer. Because the young blood making cells are coming from the patient, we don't have to deal with the immune fighting. So there is no graft versus host disease. But we do need to get those guys to stick and to make blood. Okay, next. Transplant for sickle cell disease is special, and you have to know what you're doing, and it took us a good while to learn this. And part of this is the fact that whenever we do it, whether we're transplanting a 2-year-old, a 10-year-old, an 18-year-old, and now a 48-year-old, you said, Dr. Kumar? Wow. These guys have had ongoing damage to their big blood vessels, all the little sharp red blood cells that go nick, 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 nick. So I got a little PTSD from sickle cell transplants that have gone wrong for me over the years. What we have learned, experience at Sick Kids is gentler is better. We follow the same recipe that my colleagues at Princess Margaret are using, very, very gentle transplant approach so that the kids get through it. And as Dr. Kumar pointed out, we don't have unrelated donor options. So big, and that has to do with anthropology, going back to sort of Africa and how mankind started in Africa. The heterogeneity of the immune types are way, way greater in the African population. And then we had the big mixing that happened when people married from not the same village, but from someone on the other side of the mountain, from a different country, from, a Caribbean is a mess because you got people from all over the place. You're gonna edit this, hey? But this is, so half-match donor transplants are the way to go with these guys. Next. Okay, and I just chose a different paper than was previously presented. We've now done many, many transplants, thousands of transplants worldwide over time. They all show very similar outcomes, that we have excellent survival. We have whether we use in adults, pediatrics, peripheral, different types of ways of collecting the young blood making cells. Cord blood does not work as well because we just don't have enough oomph in there. It's too little. But what does work well is cord blood and bone marrow together. Oh, just beautiful. So transplant, and what's different with bone marrow to gene therapy is that we have 30 years of experience. And those curves stay stable. And we have pregnancies, we have kids, going on into good productive lives. And the longest follow-up in a gene therapy trial is 5 years. And we treated some of the earliest patients, and they're out at 4 years. So it's getting there, but it's new. Okay, go ahead. So this is the same picture that you saw before with the, and it's what we've been using at sick kids, using an antibody radiation therapy, which I don't love, okay? And because it's kind of a gift that keeps on giving. But importantly, it is enough of a clearing mechanism that we can do the transplant with no other therapy, no chemotherapy. We can shield the gonads so that the fertility is preserved. And this is basically an outpatient regimen, very, very close to outpatient regimen. Very well tolerated, very few platelet transfusions needed. The kids look great. The biggest risk is about a 10 to 15% graft failure rate. So here, everything has got a risk balance kind of thing, ratio. Here we say, I want to preserve fertility. I don't want anyone to get really sick with the transplant. I'm going to accept some degree of graft rejection. So our new strategies are focusing on how to get rid of that graft rejection point of view. Okay, next. And this is the same, you saw that was this with Dr. Kumar, the use of half-match donors, of which a parent is a half-match donor, other siblings, 50% chance of being a half-match donor. This is the way to go, and this is where the direction of the field is going. So what I'd like to say is, we're not in free fall with transplant. We're not in a situation where if you don't have a matched brother, sister, everything's gone. There are major advances happening with half-match transplants. And so as you counsel families, you're going to have to say, well, this is a complicated space, and it's not a stable platform with recommendations. Next. Okay, gene therapy. So now remember I said we're starting with the youngest of the blood-making cells. There are many strategies in gene therapy, and the print here is small. These slides are going out to people if they want them. Okay, good. And there are many different approaches. I'm going to run you through some of the ones that are further along, but I gave you this slide on purpose to say this is a really active area of research, and you are now seeing the first of a huge number of strategies that are going to be iterated on, improved on, and coming to practice. So one take home from what I'm saying today is, and I don't know the answer to this, is when is it going to be the time to push the button to go this year to transplant with any given patient, knowing that we've got changes in treatment strategies, but also cognizant that we don't want the patient to get a serious event. We don't want them to have a stroke. We don't want them to have kidney failure or whatever, and to suffer a lot. When to push this button, and this is where we need ongoing dialogue. Okay, next. Okay, the first approved treatments have taken advantage of the fact that there's the hemoglobin switch. And I'm not going to repeat what Dr. Kumar had said, but basically, if you can keep somebody making fetal hemoglobin all their life, basically making them into a person with hereditary persistence of fetal hemoglobin, which, by the way, if you have that disorder and you also have a sickle problem or a thal problem, your transfusion needs are way less and you'd have way less pain crises. So we have a natural occurring event to show that, hey, this idea sounds a little crazy, but we have people walking around, families walking around who it works. So the idea here with the gene therapy, I'm going to talk to you first about the CRISPR Vertex product, is, hey, let's block that switch to making beta hemoglobin. So beta thalassemia and sickle cell disease, the mistake is only in the adult beta chain. Okay, so so if you don't make the beta chain, you won't have the disease. Next. So the control, and one of the good things is people have funded basic research for a long time, so a lot is known about hemoglobin control, and it's incredibly complicated. But if you take out that blue box, BCL11A, you will block the switch from making gamma globin to adult form of hemoglobin. Okay, you'll keep you in fetal hemoglobin. And the target for the CRISPR Vertex is incredibly specific. It is straight for just the red cell enhancer with the BCL11A. It doesn't touch B cells and other cells in the body. So very focused targeting. Next. And this was one of the first, or the first gene therapies that utilize CRISPR technology. So with CRISPR technology, you have a way of homing in very specifically using a piece of designer guide RNA to say, you come in and stick right here to a specific area, that enhancer for BCL11A, and cut. And anytime caspase, anytime you hear an A's on something, that's an enzyme, it's cutting, okay? So it causes indels. I'm just a blood doctor, so all these words don't, stress me until I figured it out. Deletions, insertions. So it sees this, it makes a cut. And why I liked this treatment and went in with these trials is that it does not involve a virus to do the gene therapy. Basically, we collect the patient's young blood-making cells, we put them in a flask, run an electric current through it, and it's called electroporation. It makes the cell membrane a little loosey-goosey, and this big clunk, clunk, clunk is able to get into the nucleus and do the enzyme correction, and then it's done, okay? And it's very, very targeted. A lot of work went into showing that A, it got into the youngest of the young blood-making cells, B, it didn't go somewhere it wasn't supposed to go. And we are in this phase with a 15-year follow-up on these studies to take a look at, to make sure that that's true. Next. Okay, so you saw this with Dr. Kumar. Basically, we collect the young blood-making cells, treat them, put them in the freezer. The testing is arduous on the product. It takes about 6 months. And sometimes they send you back to square one to recollect and start the whole process again. Then it's the autologous transplant, and then we get through. So you have to have very special patients and families and a need. Next. Next. Okay, now the age range that has been treated is 12 to 35. You can't have too much iron. Importantly, okay, all the reported patients with sickle cell disease had no CNS disease, okay? So they took out a big chunk of the patients who you would say, boy, these are the guys we really want to get corrected. So that's not been tested. The second is that in order to be eligible for the study, the patients had to have 2 events: vaso-occlusive crisis requiring hospitalization and, or a prolonged time in the ER, priapism, acute chest, and hypersplenic crisis. With the start of this, I screened all the patients at Sick Kids. I went through all the patients in your young adult crew, Dr. Kumar, and came up with 2 who made it through the eligibility, and one guy just got tired of going through all the processes and backed out at the 11. So we ended up treating 1 out of thousands of patients. So this is trying to get at what the patients in this first series are highly selected, okay. The major reason I had patients flunk was that when we started to look at them, I saw a high degree of pulmonary fibrosis in the sicker patients that was not apparent until we started to do pulmonary function studies. Next. Collections was terrible. there's a hesitancy to give GCSF for mobilization, so it's being done just with plerixafor alone, not the best mobilizer, and the sheer numbers of cells needed. This was a labor of love, and the apheresis nurses at were, just worked very hard to do the collections, not for the faint of heart, and challenging. The numbers of cells needed and the yields on manufacturing are high numbers of cells, and the yields are still low. So still early days. This is the first time we're doing this. Next. Okay, I'm just going to go here. I'm going to just skip this one here. So this is the same slide as Dr. Kumar showed, and you can just see that there's a lot of purple diamonds there. These were patients with a lot of pain crises, and very few afterwards. Okay, so that's nice. But I want you this time to focus on the length of follow-up here, and you can take a look at the 12-month, and you can see very few patients have made it to 2 years yet post-treatment. Okay, so this is a very young data set, and this is it, guys. This is the total N, total number, okay? Now, because it's so transformative and the results are so good, this led to fast track FDA approval, and the product is in right now at Health Canada. You are looking at the whole data set. Okay, for sickle cell, and this is worldwide. Some are in Europe, some are in US, one in Canada for sickle cell, about a half dozen patients with thalassemia in Canada, and then maybe 60 patients with thalassemia. This is the data set. So first in man trial, the trial during the time I ran it went from phase 1 to phase 1/2 to phase 1/2/3 to licensing trial in the course of 3 years. I've never seen anything like this before, and I said to the FDA, I said, is this legal? Are you allowed to do this? And I guess it is, if it is. So next. Uniformly, and what I'm looking for here is the flatness of these curves. Uniformly, the patients all had an improvement in their hemoglobin levels. A majority of it was due to the bump they got from the amount of fetal hemoglobin they're making. And looking at cells that had some F in it, okay, so I'm looking for something. So the sickling is caused actually by van der Waals forces. They're not covalent bonds. With the sickle, you're gonna, yeah, this is very dangerous for a transplanter to talk hematology in this audience, hey? But so basically, if you get some F in there, you're going to disrupt that sickling, okay? And so conservatively, it's thought that if we get, sickle trait patients are 50%-ish, sickle hemoglobin, and they're not sickling. So if we get close, 35 to 40%, we should be fine. These patients all had fetal hemoglobin that was up higher than that. Next. Yeah. Come on. I'll start talking, but bottom line, stable, okay? And on the far right side is bone marrow was taken on these patients. And the 34 cells, the young hematopoietic cells, are pulled out of that, and the youngest are the youngest, and there's stable correction now out to 2 and to 3 years, okay? So that is reassuring that even though we had a bright idea that we were getting the youngest of youngest cells corrected, we are getting the youngest. We were able to achieve that. Next. Okay, I have to do this slide here. All my patients, the thalassemia and the sickle cell patient that I treated, tremendous emotional, psychological distress once we told them they're cured. And we see the same thing in the transplant patients, of the devastating type and with real depression, heart, because suddenly, they've lived their life as a patient living with a debilitating sickle cell disease or chronic transfusions and chelations, and now they're saying they're fine. You know, wrap up your bed and walk. You're fine now, and they really have a hard time. So anybody going ahead with this treatment needs serious, real psychologic support with somebody who knows what they're doing more than me. So I sit and talk, but I don't have the skill set. And then the other thing is in our patient and others, the pain doesn't go away. If you have chronic bone pain, especially from hips, the narcotic usage and you still have a burden that you need to take care of. So it needs a good pain team to help you out with it. Next. Okay, so we've talked about it. The Exocel product is at Health Canada right now. In the, the price on it is probably going to be $2 to $3 million, if you ask me. I have no insider treatment for the drug. For the drug. I have no facts on that, okay, but that's just from looking. There still is the cost of doing the collections, doing the transplant, now, there has been health technology assessments done showing that patients with sickle cell lifelong are running a tab that's well above this cost. So this is something that needs, there's a lot of people working on this. Dr. Kumar with the CTTC is taking a lead from that working group. Okay, next. Okay, so now there is, who else is on? Editas. Okay, take everything I've said before, put in a different cutting enzyme instead of caspase 9, caspase 12. Instead of BCL11A, it's going in at the HBG promoter area. So it's something just right before that switch. It's kind of closer to where things happen. It is in the area where people who have hereditary persistence of fetal hemoglobin have their genetic mistake. So maybe it's a little more natural, that's, yeah. But basically everything else is the same. Got to collect the cells, you got to manufacture them, you got to give. And their first trial, the Ruby trial for sickle cell, and there's a thalassemia, Editas, Edithal for thalassemia, are occurring right now at you have them open? Yeah. And the first results are coming out, and they're looking very good. Very superimposable to what the CRISPR Vertex. They're about a year behind in the licensing pathway. So there's two. Next. Then you got, everybody's names are different. Lyfgenia is same hematopoietic stem cell, except this time it's using a viral vector. So a virus is used to get the material into the cell. And this time it's putting in some extra hemoglobin. And it's a special hemoglobin that's got stuff on it that makes it harder for the cell to sickle. Okay, so that's the Bluebird Bio product. It also has FDA approval. They elected, the Bluebird people, even though I tried to talk to them, that Canada's a great place to do your trials. They elected to do everything in the States. So they've not, at this point, applied in for Health Canada, but it is now approved for use in sickle cell and thalassemia in the US. Next. Okay, that's what that's saying. And it's going at 3.1 million. That's from the web, so it must be true. Next. I'm there. So, but this one is coming. You need to know Kamau is Kenyan Kaguku tribe for trusted warrior. Is a new company that's taken another approach that utilizes, next, a combination of the CRISPR and the virus to actually not just do the insertion deletion, but to actually do the correction, okay? So, oh, hey, home run, sounds good. Next. Whoa, their first patient didn't do so well, okay? And so their first patient, even though they're doing everything the same as what everyone else has been doing, hit up with low blood counts, okay? And I'm just gonna give you what I really like about these people. I like something about a pharma company, is that they presented at ASH in great detail what they saw with this patient, okay? And they took a look, and this patient, this is months, and they looked at, they really struggled. They couldn't get blood being made by this patient until they stopped the L-Trombopag, which, go figure there. And then gradually, so this was a gene approach that should have given that patient hemoglobin A, all right? Instead, this patient came up with hemoglobin F, looking like the other study. They still don't know what happened. They have gone back to their manufacturing, and they're going to reopen the trial. So there's another another player in the field. Next. Okay, patients with sickle cell disease have been driving their blood-making system hard with inflammation. You got to be careful and there is, in sickle cell anemia, higher risk of AML. When you pull out some of your own stem cells that have already been driven hard and you drive them hard again, then you put them in the body and expect them to make blood for the rest of the life after the correction. This is, in basic hematopoiesis, this isn't a good thing to do. So we are worried that there may be a risk of AML, and there have been some signals. No evidence of the viral vectors doing anything. I think it's just that we're pushing Mother Nature a little bit too hard. Next. I think I'm actually next. So next. So I'm going to just stop with this slide and just say, so who do we refer to transplant, and who do we refer to gene therapy, and how do we do this? And it's very much a moving target. We need partnership. At Sick Kids, we're working very closely with the hematology team, all sorts of patient advocacy. This is not a stable field, but my goal today was to show you it's not just Casgevy or nothing. There's a lot coming down the pipeline. That's the Exocel product. I wanted to show you the total number of patients treated, not a lot of patients treated. And so I think just everybody take a deep breath, but take the hydroxyurea, prevent the secondary diseases, watch your patients, and that's it. Thank you.
Thank you so much, Dr. Wall, and I really, truly apologize. We're on a tight schedule here, and I have to run a tight ship. But are there any questions folks have for Dr. Wall? Beautiful. Or Dr. Pastore? So, not to be forgotten, of course. We have about 5 to 10 minutes, so maybe we can take 3 to 4 questions before going to the next session.
Sorry. Thank you so much for that wonderful presentation. I have one question. You talked about like how the fetal hemoglobin is, part of what we're going to be using for the gene therapy. I just wanted to know if, you said that some people have it already in their body system, but what are the long-term adverse effects of having that in your bloodstream? I don't know. Yeah.
So they're your own cells, and so the question, we don't know. The longest follow-up is 5 years, period. And a little bit longer for the Bluebird bioproduct. And so we are still watching and waiting. So far, the patients are looking good. The hemoglobin production is good. Their quality of blood making is good. The amount of red cell breakdown, the hemolysis is less. Apart from dealing with the psychological stress, they're doing very well, but incredibly small number of patients in early days. But so far, everything looks good.
Sorry, one more question. Not necessarily in the sickle cell population, but like in other adults that still have the fetal hemoglobin, is there any long-term effect of having that more?
Okay, I'm going to pass this to my colleague, the real hematologist.
So I'm not going to make any transplant comment because I'm going to be laughed at. So, no, you know what, we know of people that lives with persistent fetal hemoglobin, there is no effect, right? It's a very, it's a benign condition, right? You know, they live perfectly healthy. Patients that have the combination of hemoglobin S and persistent fetal hemoglobin have very few symptoms and are not at great risk of severe complications. And actually, that knowing those patients with persistent fetal hemoglobin had much fewer symptoms. That's what led to the development and the interest in hydroxyurea, because one of the things that hydroxyurea does is that it raises the fetal hemoglobin, right? So I think, you know, one of the main questions is, we know that living with high fetal hemoglobin is perfectly fine. What is going to be the long-term effect of the gene therapy itself and, you know, all the process that is going through, that part we don't know yet, right? So I think we have very good signal, positive signal in terms of safety, but I think we still have a lot to learn about this. But I'm not concerned of having high fetal hemoglobin.
This question is for Dr. Wall. I actually have two. One, with your work as a pediatrician, I know that there's Ontario newborn screens that are done for like the sickle cell and beta thalassemia, and so we are able to catch some of the newborns with this. So do you follow them, or are they followed through afterwards, the ones that are diagnosed? And are they eligible, or are there any children's studies that are eligible for this? And the second question is, you also talked about viral vectors. Which virus are you using?
So just for newborn screening, this is something that happens in now almost all provinces across Canada. So once a baby is diagnosed with sickle cell disease, the baby is referred in one of the referral center, and they are being taken care of since they're a very early age. It means that we usually see them, you know, before the 1 or 2 month old, and then they are seen regularly to make sure that they develop as less symptoms as possible through using preventive approach, through using early use of hydroxyurea, for example.
So those patient populations that are diagnosed early, do they tend to have sickle cell as an adult?
So those patients will have sickle cell disease. So they have been diagnosed with sickle cell disease. What we observed is that when this is something we've recently evaluated in the Quebec newborn screening, we certainly have demonstrated that taking care of those babies early on by using preventive approach, they grow healthier with less disease burden than patients that have been diagnosed later on. So there is an absolutely clear benefit of having newborn screening. And you know, for different virus used, I'm going to leave that to Donna.
So there are a couple of viruses, but the lentiviruses, which is a corrupted form of the HIV virus, which is used very heavily in other gene therapy applications, and then the adenovirus, AAV6, is been the one.
Hi, Donna. Oh, hi. Donna, this is just because I think the biggest barrier for gene therapy is going to be the myeloablation piece. I'm a hemophilia doc, and gene therapy in hemophilia is they use the viral vectors, so you don't have the myeloablation. Yes, there are some issues with the virus. You get some hepatic inflammation, that kind of thing, but to me, it's a much better framework than the myeloablation. Very interested in that one. So is that the only group that's doing the viral approach, or is there other viral approach to gene therapy?
It's the group that's farthest along. But it's still ex vivo. And so the difference with the hemoglobinopathy is that you need to correct a majority of the cells, as opposed to with hemophilia, you get a 5%, 10% production of your clotting factor. You're moved from very severe to less severe, and then you get a little bit more. So it's a numbers game. There's a lot of really smart people that are working on this, and then the obvious ones, which, as transplanters, we've been trying to do this for decades, where we try to do non-chemotherapy preparative regimens, especially for patients who don't have malignancies. It's just been a tough nut to crack. So, but people are still working on it. So ideally, you get a shot in the arm, and it knows how to get into the bone marrow, and we're not there yet.
Okay, so we have room for 2 more questions. So I see Bianca, Joy. In the interim, if folks could just complete our quick survey by virtue of scanning the QR code. We have hard copies as well if people need them, but I'm going to pass it to Bianca now to ask our second last question.
Thank you, Dr. Wall. I was just curious, if a patient were to ask us, as clinicians, which one over the other, in terms of the different options, what would be your recommendation for us? And then my second question was just more so about the process, why are we not using GCSF or versus the Plerixafor?
Yeah, so the concern with the GCSF is that it'll cause sickling in the bad way. And so you don't want, now I've argued against it, but I've gotten overruled by hematology colleagues. Because these patients have all been heavily transfused, so they don't have much sickle cell in them. So that was the second question. The first, so which one? So right now, nobody is licensed in Canada. And then the other caution here, and so we do tons and tons and tons of consultation, either together with our hematology colleagues. Often I'll do a Zoom with the hematologist from the site plus myself, and run through sort of where the field is. The recommendation this year is going to be very different than next year, and it is rare, especially in pediatrics, that you have to go now. Now, that all may change as we understand the biology of this disease, and there's a push to transplant younger. But there we'd probably, to treat younger, there we'd probably go with transplant.
Thank you very much. For the new therapies, should we be recommending them with the use of hydroxyurea or chronic transfusions? Because for patients, for example, the Therapies in patients, it did reduce their number of crises that way, but were they on hydroxyurea?
So, I think for Therapies it's really, it's a very difficult complications to deal with. I don't think that single medications may be helpful. So I think you would need to get combination therapy. And I think, if I'm thinking of what we're going to do in the future, I'm really thinking we're going to use more combination therapy, as I said earlier, rather than using, one instead of the other. If you have a naive patient, by definition, someone that has received no medications specifically for sickle cell disease, you might have a stepwise approach. Which one are going to use first? I think we will have to learn more on how to use those new medication, right? So if I have a very severely anemic patient, maybe I would like to start with voxelotor, but as voxelotor may not, protect that patient well enough against pain crisis, quite early on, I would expect that you will need to add hydroxyurea. I think one of the things that we need to teach our patients is the caution that those medications so far, we're not at a step that it will replace hydroxyurea. So we need to continue to use hydroxyurea. It is a, really excellent drug in terms of efficacy and in terms of safety. We've used it for such a long time, and it's been such extensively studied that I think we really clearly can state it is a safe medication, and we can continue to use it.
Perfect. What a perfect close. So to that effect, folks, I cannot implore you enough. We really value your feedback. So if you could fill out the survey before you leave.
Yes.
But it is now time to break for lunch. Lunch will be served in the same area as we had this morning for breakfast. We also have a poster presentation in the butternut room, which is basically you hang a right once you exit through these doors, and that we will